Welcome, everyone. My name's Alex Wade. I'm a clinical nurse consultant in hepatology and team leader of an amazing team on the mid-north coast of New South Wales in Australia. I work for HIV-related programs, and my part of that is the viral hepatitis service. Under HIV-related programs, we have HIV sexual health service, we have a needle syringe program, we have some harm reduction. Can you get that, please? Sure. It's just one of our speakers. And our viral hepatitis service. So I'm actually a little bit out of my lane today, so I'm looking forward to learning from our experts in the area. In that I'm actually a viral hepatitis nurse. I have a brief history of sexual health nursing prior to falling into the field of viral hepatitis, which I just loved. Working in sexual health in general practice land, and then coming across and doing some casual work with our sexual health service for a couple of years, which was really insightful. And that was in 2010, 11, I think it was. And so I haven't done sexual health nursing for a long time, and I know that things have changed in that space. So I'd just like to do some housekeeping, because I've just seen that there's this form in front of me here, which I better do or I'll get in trouble. Today, one of our speakers is actually going to speak in her native language, so we are going to need to use the translation app. If anybody's had a chance to play with it, it's actually amazing. If you don't have earphones, it will actually translate on the app, and you can read along with the transcript. But she's not here yet, so she's going to be at the end of the panel session, I think, may be the case. So the Wordly app is just on the QR code there. It might be an idea to try and just get that onto your phone now, so that when she is ready to do her session, we'll be ready to listen up big. Please stick around for the closing session to hear from our rapporteur speakers and hear some fun highlights from the conference. I had the great privilege of doing rapporteur last year. I can say it's a privilege this year because I'm not doing it. Last year, I can tell you it was very nerve-wracking, but it's really worthwhile sticking around for, because you get to hear some fantastic highlights from the conference, and also those guys have had to pay attention all 3-4 days to put that together, and so it's great for us to stick around and to hear them out. Yes. Oh, you've got to love it. What do they say? The pelican has landed? I'm sure it's not the pelican, but I am from Australia, so you never know. So our session today is emerging issues for nurses, chemsex, STIs, and harm reduction among people who use drugs. Now, none of us are experts in the world of chemsex as such, but I think we can all agree if we're working with people who use drugs, there's a good chance that they're having sex, and so we have an intersection there, and it's worth talking about because there are some new and innovative things going on in that space, and so it'd be really great for us to have a deeper understanding as nurses and what we can do and how we can actually be more mobile in that area, whether or not we're working in sexual health or viral hepatitis or health promotion. So, excuse me. I'm from New South Wales in Australia, and I recently went to a fantastic talk that they came up with. It's a research study called Method. I don't know if anybody's familiar with it, and it is actually a guide to safe chemsex, which is the way they kind of put it across, chemsex harm reduction education guide, which is a fantastic thing. And so it's nice to see that this is like becoming a bit of a topic, and there's actually some education around, and stay hydrated, make sure you've got a mate around, and all sorts of really good information. So I'll have that with me. There's a QR code in there so people can actually get the electronic version of it, and it's available to everybody to use. So I'll have that at the end of the session if anyone wants to actually QR code that. So, without further ado, what I will do is hand over to our first speaker, and I'm going to let Jeremy introduce our first speaker. Julian. Jeremy.
Where's Jeremy?
Julian.
Don't worry.
Sorry, man.
Where do we stand? Is it here?
You can do it there if you like.
Is this working? Hello, everyone. My name's Julian. Nice to meet you. Let's see if this is working. Oh. Ooh.
Oh. Got a whole heap of slides there.
There's some slides, there's our names and stuff like that. Let's see how we're going. Then it's finished. keep going?
Yeah, can I have that for a minute?
I'll start talking anyway. My name's Julian. I'm a nurse by trade. We're part of the Find and Treat team, so we're a pan-London inclusion health team. We started off originally as being like the TB gang, so we had this big truck that you'll see a picture shortly, imminently, which would go around and doing chest x-rays for people at risk of TB, tuberculosis, and going to homeless settings, any kind of congregate settings for people at risk. And, oh, I can see it over here, so we're getting close. Over the years, we've added different interventions. So at the top right, you see our truck. That's got a chest x-ray machine on it. We can go zap people. It takes about 30 seconds. People don't even have to take their clothes off and stuff like that. And over the years, it's got a clinic room on the back. Over the years, we've added various interventions on top of that. So you can see there's someone having a chest x-ray up there. We've added vaccination service on the back of that. Obviously, COVID, but pre-COVID, we were doing about 2,000-3,000 influenza vaccines a year. Struggling to get commission to Hep B, which is ridiculous, so let's not go there. Pneumococcal vaccines, obviously COVID more recently, and I'm part of the BBV gang, so the bloodborne virus team. So in the UK, we're pretty well funded, to be honest, about Hep C funding for elimination. But what we do, we've got a lovely commissioner, Mark Gillian-Powell, who's very understanding at us being able to push the envelope for our testing budget, as you'd all understand. If you're doing a finger prick test for Hep C, you're doing Hep B, we can do HIV, we can do syphilis, and we also do some STI testing on the back of that. Quite a strong component, a lot of people with lived experience in our team. More than half of the BBV team are people with lived experience, peers, whatever you want to call them. None of them are here. I think John's having a coffee, he's on his way, and James is doing some shopping, but they've been working very hard, so they deserve a bit of a break. So let's, essentially we kind of, it evolved over time. In the middle of COVID, we decided to do this outreach sex worker session. So street-based sex workers in North London. And I'll hand over to Sive in a second, but all of our kit, as you know, you can point all this kit. We've got a GeneX machine, we've got FibroScan, we've got people lived experience, we've got the know-how, and we've got the mobile teams that we can just go out and zap people. Oh, the miss. Can we go backwards? Is that we've also got a bike. Yeah, there we go, down there. We're not allowed to do a presentation if we don't introduce its bike, which is also an electric powered bike. We've got a Kefi gene experts on that and a FibroScan as well. So I just wanted to mention Injit's bike, otherwise we need to get it out more. And I'll hand over to Sive, who's been really leading. She's been key in leading this bit of work. It's great, it's heart-rending, and the risk we're getting with these people of the street-based sex workers is pretty grim, to be honest. And I found it we're all used to sort of the tragedy of life, unfortunately. But I find it's been particularly a bit of a journey to be a bit cheesy. But I'll hand over to you. Do you want to swap over?
Sure.
Yeah. Thank you.
Hi, I'm Sive, one of the inclusion health nurses on the Find and Treat team. Yes, okay, this looks a bit different, but so this particular bit of work is a partnership that we have created between ourselves and another organisation, which is also part of the NHS, called SHOCK, which is Sexual Health on Call. I'm going to be kind of jumping back and forth between ourselves and them, but essentially the Find and Treat offer, as Julian has kind of already spoken. Oh, thank you. Yeah, thanks. So we have the rapid state-of-the-art diagnostics via GeneXpert. The point-of-care tests take about 15 minutes to result. And then we can do self-swabs or urine samples for chlamydia and gonorrhea, and then a lab-based swab for trichomoniasis. We can do on-site treatment for chlamydia and gonorrhea, so there and then, as I said, it takes an hour and a half for those results to come back. So if the client is still around, we can offer a treatment there. Unfortunately, with syphilis, it's a little bit trickier because we're not technically like a clinical space, so the coverage is slightly different now. In certain circumstances we have done it, but it's kind of a case-by-case basis. We also do onward referral and support to navigate services for other infections, and referral for HIV PrEP. The harm minimisation stuff is needle and syringe packs, and rapid referral to drug services. And then we do all the soft stuff as well, so hot drinks, food, packs containing essentials, so sanitary products, toiletries, and vulnerability assessments. And we have rapid referral pathways into emergency accommodation, drug services, as I mentioned, contraception, the IDSVA, so the Independent Sexual Violence Advocates, and kind of any other NHS service that you might need.
Oh, sorry, yeah, must.
And then the SHOCK guys, so unfortunately they're not here, but they have been operating in the area since 1996. and have been providing night outreach since the beginning. So they've been there for a lot longer than we have. And their primary aim is to provide sexual health services and broader social support to street-based sex workers, particularly women with multiple and complex needs. So we kind of piggybacked on the work that they were doing because they'd already built up that like trust and relationship, and they had that like positive reputation. So we were able to kind of start going out with them and quite quickly build up that trust because they were coming alongside us. Next, please. So the partnership started in 2020 to co-facilitate the night outreach service providing sexual health care for people selling sex in North London. So kind of, it brings both services like expertise together. So we kind of set up shop. We have the van parked up in the same area all the time, and the other team, the shock team, go out and drive around to well-known areas and signpost them to the van. They provide material aid, emotional and practical support, and as I said, yes, signpost to us. So we go out. It started off in 2020 as kind of a monthly thing, really, but off the back of a new HIV diagnosis in the summer of last year, we ramped that up as kind of a public health response. So we're going out twice a month, and that's kind of continued since. Fortunately, we haven't had any further new diagnosis, but just in terms of that case as well, like obviously we didn't prevent the transmission of her. You know, she did end up getting HIV, but on the positive side of that, she's now engaged in drug services. She's working much less. She's been undetectable since diagnosis, and there's still a lot of like there's no slide for that. I'm just talking.
Oh, sorry.
There's still a lot of like internalized stigma for her, but she's made like leaps in the year really that since diagnosis. That's one of the like more positive stories, I suppose. So just a little bit about. Will you go back one or forward? Sorry. Yeah. So in a year period, this is the shock guys again, so May 23 to 24, they had 353 contacts with sex workers during street outreach. This includes people that were both seen and signposted to the Find and Treat van, but not all of who attended for testing. 31 of those contacts attended level 3 sexual health services that are specific for sex workers, and 4 of those women accessed terminations. And then some of our, some of our data. So we have, since 2020, December 2020, 42 outreach clinics, 145 encounters, 115 of which have included testing. So a lot of the women will come on the van. They don't necessarily want testing, but it's a safe place. It's somewhere warm, especially in the winter, or somewhere away out of the rain for like half an hour just for a chat. So it's that stuff for us is as important as the testing, is just providing that kind of safe space for them. But some of the results there's 11.5% Hep C antibody positive, 1.8 Hep B, 1.2 HIV, 28.4% syphilis, so really, really high, 21.8% chlamydia, and 19.8% gonorrhea. Some of the other outcomes, so 70% are UK-born women, and all of the UK-born women have reported experience of homelessness, sexual violence, drug use, and complex trauma. The majority of the non-UK-born women were Bulgarian or Romanian, reporting contraception needs and issues with trafficking and sexual exploitation. So kind of going back to the holistic stuff that we try and do, so offer support around drug and alcohol use, homelessness, so rapid referrals into housing pathways, support with family and domestic violence, and trafficking and modern-day slavery. We had a really good working relationship with the police in the area up until about 6 months ago. There was a specific team that were the guy that was heading that was amazing, and like really understood what we were trying to do, and like they what do they call it, some sort of like corridor, where they basically didn't come out policing on the nights that we were out, so that the women were more likely to engage with us. So that positive working relationship was really fostered over a couple of years. Unfortunately, that team has now changed, and we're seeing like increased rates of like ASBOs, kind of like antisocial behaviour orders, or women being told not to be in the area, which obviously, as we all know, is just making it much more unsafe for the women if they're, you know, kind of trying to do it down dark alleyways, as opposed to it being a little bit more visible. So that relationship, we're still in contact with the police and are trying to, I guess, encourage them to go back to the way it had been before. Next, please. So yeah, the challenge is ongoing, as I said, ongoing changes to policing and political landscapes regarding concerning criminalisation of sex work. There's lack of continuity in positive policing initiatives, the geographical limitations of secondary and tertiary sexual health services. So the service that we do refer the women into is 40 minutes probably. Now there is closer services, but how friendly they are to sex workers is, part of the issue, and consistent underfunding. And in conclusion, the collaboration aims to remove barriers to accessing traditional sexual health care for women who experience multiple marginalisations. We not only address sexual health needs, but also aim to tackle other health and social inequalities. We've established a trusted service for this vulnerable cohort and have contributed to a reduction in BBV and STI transmission. And the results show collaboration has identified and treated incidences of BBVs and STIs in this cohort and provide linkage to other health and social care needs. Thank you.
With plenty of time to spare.
I can start again.
Thank you so much for that. What amazing work out there on the streets, it's really encouraging, inspiring. What I thought I might do while Martha gets ready is just flick back to some of those earlier slides and just introduce the nursing group, which I was remiss at doing. A little bit anxious about this session today, so bear with me. Can I go back? Is that okay? Can I go back to the... Oh, actually, he's already taken... Oh, here we go. So this session comes about as there's a nursing committee for INSU, and I've been involved for the last 2 years. It's been an amazing group of people to work with, and we have been able to actually build the nursing cohort into the actual program, which has been really exciting. And any who came on the very early breakfast meeting, and I know there were some who just ditched us completely because it was way too early, but we were really grateful for those who did attend and also completely understand being ditched. So there's no no offence taken. It's just a really lovely way for nurses to connect throughout INSU, and I know that I've seen a lot of people through the last 3 days, and it's been lovely to kind of go, hey, how's it going, and connect up. So we hope that this continues, and as just a brief introduction to the members of the nursing group as it stands today, and a big thank you to that group and the coordination through this process. And then, that's backwards. Get involved. We may have done it the other way around this time. We chose a topic and then sent out for EOIs. We're thinking of reversing that. So please think about what you would like to talk about as a nursing group. And after this conference that they're kind of doing all their wrap-ups, you may get sent an email to ask if there's anything you'd like to present on and to put in an EOI. You can see that it's actually really easy. It's just an email to Brooke. We'd love to hear from you. We'd love to hear about your work. We're really interested, and it's really interesting, as you can see, just from the speakers that we've had so far. So please get in touch. If you've got any other ideas or other nurses in your area that might like to come along, let's expand our presence. I actually went to I think it was at the AGM, or the GAM as it's called, and nurses are a really big wedge of the INSU membership. So let's represent. Okay, that's our session. They're going to be our speakers, and I didn't get not the greatest chair today, so just forgive me. These are our beautiful panel members, and I will come to them, but I think, Martha, if you're ready, you're right to come and do yours. Yeah, great. So, have we got slides loaded for Martha? Yes, we do. We do. There will be an app. There is an app, yeah. So I'm just checking that we're... Oh, wait, stop pressing the button. I think I was being told then. Should have heard me with the bell yesterday at the first session. I do love a bell.
It's in your guidebooks, the translation session.
Oh, yes, it's also in there. Thank you.
Καλησπέρα. Με λένε Μάρθα Παπαδοπούλου. Δεν ξέρω, σας μεταφράζει το application. Να κάνουμε ένα check. Everything is okay with the app? Okay. Ευχαριστώ για την κατανόηση που η ομιλία θα είναι στα ελληνικά. Είναι πρωτόγνωρη εμπειρία για σας. Ίσως είναι και η τελευταία. Yes, okay. Okay, slower. I don't know about the time. Okay, let's begin. Το θέμα μας σήμερα είναι το chemsex, PrEP και σεξουαλικώς μεταδιδόμενα νοσήματα. Και ας πάμε στον ορισμό του chemsex. Επινοήθηκε από τον David Stewart το 56 Dean Street. Πρόκειται για τη χρήση συγκεκριμένων ψυχοδραστικών ουσιών, συχνά σε συνδυασμό μεταξύ ομοφυλόφιλων και αμφιφυλόφιλων ανδρών, αλλά και ανδρών που κάνουν σεξ με άντρες, τρανς και μη non-binary ατόμων. Συνήθως περιλαμβάνει πολλαπλούς συντρόφους, group sex και σεξουαλικές δραστηριότητες που μπορούν να διαρκέσουν από ώρες έως ημέρες, συνήθως Σαββατοκύριακα. Οι εφαρμογές γνωριμιών παίζουν τεράστιο ρόλο στην πρακτική αυτή. Μπορείτε να δείτε τα application εδώ πέρα. Το πιο γνωστό από αυτά είναι το Grindr. Και ας δούμε ποια είναι τα κύρια ναρκωτικά που χρησιμοποιούνται. Είναι η μεθαμφεταμίνη, crystal meth αλλιώς, που αυξάνει την ενέργεια, τη λίμπιτο, μειώνει τις αναστολές.
Speaking Greek, so that translates to whatever language that you need. Is anyone able to do that? No. I don't think it's translating, Diane.
It is sort of.
Yeah.
Speaking Greek.
Speaking Greek to English.
Oh, right. Yeah.
Oh, Alifia, really?
Oh, yeah. Yeah.
Oh, no.
Sorry, I'm a Greek.
So it was right.
So we need to change the language at the top to Greek.
Ah, there we go,
It's
yes.
not, I'm not able to change it. So,
Doesn't it just...
so it's actually not working.
Oh, no.
So I may be guessing that it's the first time that it's been used.
Oh, wait.
Yeah,
Mine
should
just
do it.
did for some reason.
I start again.
Mine just changed, Alex.
Yeah. Yeah, it's fine. Should just
Start again.
takes time.
Yeah, I was like, oh no.
Αλεξάνδρα, είσαι φανταστική.
Yeah.
Yeah, perfect.
Thank you.
Να ξεκινήσω από τον ορισμό ή κανονικά πάω? From the beginning or from main drugs?
Just like, yeah.
Okay. Okay. The presentation is in English, okay. Yes. Well. Λοιπόν, τα κύρια ναρκωτικά που χρησιμοποιούνται στο chemsex είναι η μεθαμφεταμίνη, crystal meth, που αυξάνει την ενέργεια, τη λίμπιτο, μειώνει τις αναστολές. Μπορεί να προκαλέσει παρατεταμένη σεξουαλική δραστηριότητα. Το άλλο είναι το γάμα υδροξιβουτυρικό οξύ, GHB, GBL. Συχνά αναφέρεται ως G, υγρή έκσταση και τζίνα, γνωστό για την πρόκληση εφορίας, τη μείωση αναστολών και την ενίσχυση της σεξουαλικής ευχαρίστησης. Εδώ έχουμε τον κίνδυνο για υψηλή υπερδοσολογία, ειδικά όταν το χρησιμοποιούμε μαζί με αλκοόλ. Το άλλο ναρκωτικό είναι η μεφεδρόνη. Και αυτό είναι διαργετικό φάρμακο που μπορεί να αυξήσει την εφορία και τη διέργηση και συνδέεται με έντονη σεξουαλική δραστηριότητα. Μετά είναι η κεταμίνη, που χρησιμοποιείται και στο chemsex, αλλά περισσότερο είναι για να αναστέλει, να μειώνει τον πόνο και να χαλαρώνει το άτομο. Και πιο σπάνια, αλλά χρησιμοποιείται η κοκαίνη. Και αυτό είναι και φημίζεται για τις διαγερτικές του επιδράσεις, αυξάνοντας αυτοπεποίθηση και την κοινωνικότητα. Όλα αυτά τα φάρμακα που συνδυαστικά μας κάνουν τα Chemsex χρησιμοποιούνται μαζί και με poppers, που είναι αμυλικά και αλκυλικά νητρίδια, το MDMA, την κάναβη, το αλκοόλ και το Viagra. Here are the drugs. Ας προχωρήσουμε τώρα στο τι προκαλούν στον εγκέφαλο. Ας πάρουμε για παράδειγμα τη μεθεδρόνη. Απελευθερώνει ντοπαμίνη, η οποία είναι ένας βασικός νευροδιαβαστής που εμπλέκεται στην ευχαρίστηση, δημιουργώντας αυτό το αίσθημα εφορίας και αυξημένης ενέργειας. Επίσης, απελευθερώνει και σερωτονίνη, ενισχύοντας τη διάθεση, το συναίσθημα, την κοινωνική συμπεριφορά και μοιάζει και αυτό με το MDMA. Απελευθερώνει και νορεπινεφρίνη. Αυξάνοντας την νορεπινεφρίνη, η μεφεδρόνη αυξάνει την εγρήγορση και τη σωματική ενέργεια, οδηγώντας σε αυξημένη διέγερση. Συνολικά, λοιπόν, η μεφεδρόνη δρά ως διαγετικό παράγοντα με αυξημένη αισθητηριακή αντίληψη. Παρ' όλα αυτά, όμως, οδηγεί και σε αρνητικές επιδράσεις, όπως άγχος, παράνοια και εθισμό, λόγω της ταχείας εξάντλησης αυτών των νευροδιαβαστών και της υπερδιέργεσης των οδών ανταμοιβής του εγκεφάλου. Και όπως βλέπετε εδώ συγκριτικά, στο διάγραμμα, βλέπουμε σε σχέση με την κοκαίνη, το σεξ από μόνο του και την νοικοτήνη, σε τι ποσοστά υπερδιέργεσης φέρνει τον νευροδιαβαστή. Και εδώ βλέπουμε το φαινόμενο Chemsex και τις συνέπειες που έχει γενικότερα. Αποτελεί κίνδυνο για τη δημόσια υγεία για λόγω της HIV μετάδοσης και των σεξουαλικώς μεταδόμενων νοσημάτων, της υπατήτητας C, της οπεδεσολογίας ναρκωτικών και της τοξικότητας. Έχει επιπτώσεις στην ψυχική υγεία με εθισμό και εξάρτηση, διαταραχές ψυχικής υγείας, μοναξιά, απομόνωση. Επιπτώσεις στην κοινότητα, γιατί στιγματίζει και περιθωριοποιεί. Έχει επίσης και με τους επαγγελματίες, τους παρόχους υγειονομικής φροντίδας, γιατί τους δημιουργεί εμπόδια και επίσης και εκεί υπάρχει το στίγμα και ο ρατσισμός. Επίσης, έχει και τις πολιτιστικές και κοινωνικές αλλαγές με τη ψηφιακή κουλτούρα γνωριμιών και εφαρμογών, τη σεξουαλική ταυτότητα που μπορεί να έχει ο καθένας και την έκφρασή του. Και επίσης διεγείρει κοινωνικά και νομικά ζητήματα, όσον αφορά με την ποινικοποίηση αυτών των ουσιών, την εκμετάλλευση, τον εξαναγκασμό και ζητήματα συνένεσης ανάμεσα σε αυτούς τους ανθρώπους. Και να δούμε πιο συγκεκριμένα όσον αφορά τη δημόσια υγεία και τους κινδύνους, είναι η μετάδοση του HIV και των σεξουαλικώς μεταδόμενων σωμάτων, με μη ασφαλείς σεξουαλικές πρακτικές, με μη χρήση του προφυλακτικού και τους πολλαπλούς συντρόφους. Τη μετάδοση υπατήτητας Β και Σ, όταν χρησιμοποιούνται κοινές σύριγγες και όλο γενικότερα βελόνες και pipes, και η γνωστή μέθοδος που χρησιμοποιούν τις συγκεκριμένες ουσίες λέγεται slamming, όπως φαίνεται και στην εικόνα. Η ενέσιμη χρήση ενδοφλεβίων ουσιών, των συγκεκριμένων ουσιών. Ένας άλλος κίνδυνος είναι η τοξικότητα και η υπερδεσολογία, από το THB, το HBL, μεθαμεταμίνη, μεφεδρόνη. Αυτά έχουν μεγάλο κίνδυνο υπερδεσολογίας. Ειδικότερα, είπαμε, όπως συνδυάζονται με αλκοόλ και άλλα ναρκωτικά. Και ποιος είναι τώρα ο ρόλος των νοσηλευτών σε όλο αυτό το φαινόμενο και ποια είναι οι στρατηγικές μείωσης βλάβης? Είναι να γίνεται ασφαλή χρήση αυτών των ουσιών, να υπάρχει αποστηρωμένος εξοπλισμός, να γίνεται εκπαίδευση για τη σωστή δοσολογία και τις αλληλεπιδράσεις που έχουν μεταξύ τους αυτά τα φάρμακα, προσφέροντας ξεκάθαρες πληροφορίες. Επίσης, καλό είναι να χρησιμοποιούμε χώρους επιτήρησης χρήσης αυτών των ουσιών με τα shooting galleries. Άλλος παράγοντας, άλλη στρατηγική είναι η προαγωγή της σεξουαλικής υγείας. Να χορηγούμε προφυλακτικά, λιπαντικά, η χρήση της PrEP, της PEP, της DoxyPEP και DoxyPrep, θα τα πούμε και πιο αναλυτικά τα συγκεκριμένα. Να γίνεται εξέταση για τα σεξουαλικώς μεταδιδόμενα νοσήματα συχνά, και σίγουρα ανά 3 μήνες, χωρίς να υπάρχει αίσθηση κρίσης και να υπάρχει μια εμπάθεια και μια ενσυναίσθηση σε αυτούς τους ανθρώπους όταν έρχονται να τους κάνουμε αυτές τις εξετάσεις. Και να τους λέμε να ενθαρρύνουμε για πιο ασφαλέστερες πρακτικές όταν κάνουν group sex και Kemp sex. Να αποφύγουμε την υπερδοσολογία. Και πάμε να δούμε πιο αναλυτικά λίγο για την PrEP. Για όσους δεν τη γνωρίζουν, είναι η προφύλαξη πριν την έκθεση. Χρησιμοποιούμε 200 mg εμτρισίτα με 245 mg tenofovir disoproxil fumarate, το DDF ή το TAF. Πλέον υπάρχουν και τα long-acting injectable PrEP, cabotegravir, την οποία χορηγούμε κάθε 2 μήνες. Έχει εγκριθεί από τον FDA το 2021 και το lenacapavir 2 φορές το χρόνο, το οποίο περιμένουμε να εγκριθεί προς το τέλος του 2024. Επίσης, η PrEP ξέρουμε ότι μειώνει τον κίνδυνο σεξουαλικός της HIV λίμωξης πάνω από 90% και μάλιστα αν λαμβάνεται καθημερινά βάσει αυτής της πρακτικής φτάνουμε το 99% και σε όσους κάνουν ενδοφλέβεια χρήση ουσιών η προστασία φτάνει πάνω από 74%. Χορηγούμε ή καθημερινά ένα χάπι την ημέρα, συγκεκριμένη ώρα, ανεξαρτήτως φαγητού, ή είναι η PrEP on demand, όπου δίνουμε 2 χάπια μέχρι 22 από 24 ώρες πριν την επαφή, ένα χάπι την επόμενη μέρα και άλλο ένα χάπι τις επόμενες 48 ώρες. Αν συνεχίσει όμως αυτή η πρακτική, συνεχίζουμε και τις επόμενες μέρες να λαμβάνουμε ένα χάπι. Όσον αφορά την PEP, που είναι post-exposure προφύλαξης, αυτό είναι αν έχουμε γνωστή έκθεση με κάποιο θετικό άτομο στο HIV, λαμβάνουμε για 1 μήνα αντιρετροϊκή θεραπεία. Είναι ένας συνδυασμός αντιρετροϊκών. Αλλά αυτό που είναι σημαντικό και πρέπει πάντα να θυμόμαστε, ότι υπάρχει ένα παράθυρο 72 ώρων που δεν πρέπει να ξεπεραστεί. Και πάμε να δούμε τώρα την DoxyPEP και DoxyPrep. Η DoxyPEP είναι μια νέα τακτική που χρησιμοποιούμε για να αποφύγουμε τη μετάδοση των βακτηριακών σεξουαλικών μεταδεδομένων νοσημάτων. Είναι αντιβιωτικό, είναι δοξικυκλίνη, η οποία χορηγείται σε 200 mg δόση μέσα σε 72 ώρες, ακολουθούμενη από μια σεξουαλική έκθεση. Δεν παίρνουμε όμως παραπάνω από μια δόση την ημέρα, δηλαδή παίρνουμε 100 mg τη μία μέρα. Είναι καλά ανεκτικά με το γαστρεντερολογικό και το μόνο πιθανός κίνδυνος είναι η φωτοευαισθησία που προκαλεί. Κλινικές μελέτες δείξαν ότι η DoxyPEP μειώνει τη σύφυλλη 70 με 80% και τα χλαμίδια 70 με 90%. Παρ' όλα αυτά, λόγω της αντίστασης στα αντιβιωτικά, δεν είναι τόσο καλή στο να προστατεύσει τον πληθυσμό από τη γονόρεια. Γι' αυτό είναι σημαντικό να συνεχίζουμε να κάνουμε διαγνωστικούς ελέγχους κάθε 3 μήνες. Τώρα, όσον αφορά την DoxyPrep, είναι ένα διαφορετικό δοσολογικό σχήμα, όπως λέει και PrEP, pre-exposure. Αυτό δίνεται από πριν, ένα χάπι την ημέρα, 100 mg, συνεχόμενα. Αυτό βέβαια ακόμα δεν έχουν γίνει πολλές μελέτες πάνω σε αυτό, αλλά χορηγείται. Περισσότερο χρησιμοποιείται η DoxyPEP. Και πάμε να δούμε πού αλλού χρησιμεύουν, πόσο σημαντικός είναι ο ρόλος του νοσηλευτή σε πόσα άλλα ακόμα πράγματα όσον αφορά αυτό το κομμάτι. Είναι να αναγνωρίζει τη συμπεριφορά κάποιου που κάνει Kemp sex. Ειδικότερα σε τμήμα επιγόντων περιστατικών, σε σεξουαλικές κλινικές υγείας, σε προγράμματα αποκατάστασης. Είναι πολύ σημαντικό να γνωρίζεις και να αναγνωρίζεις αυτούς τους ανθρώπους. Επίσης, είναι καλό να ξέρουμε να διαχειριζόμαστε μία υπερδοσολογία. Να ξέρουμε τα ζωτικά σημεία, πώς θα τα χειριστούμε, τα αντίδοτα και να προσφέρουμε υποστηρικτική φροντίδα. Επίσης, αυτούς τους ανθρώπους μπορούμε να δώσουμε και να τους συνδέσουμε με προγράμματα τα οποία θα δώσουν, ανάλογα τα ναρκωτικά που χρησιμοποιούν, μεθαδόνη ή ιβουπρενοφίνη και γενικότερα να υποστηρίξουν. Επίσης, σημαντική είναι και η διαθεσιμότητα της ναλοξόνης. Εάν οπιοειδή χρησιμοποιούνται στο Kemp sex, η ναλοξόνη είναι ένας πολύ σημαντικός παράγοντας σε αυτό και να εκπαιδεύσουμε τους κύκλους αυτών των ανθρώπων για να αποτρέψουμε τη θνησιμότητα από την υπερδοσολογία. Επίσης, οι νοσηλευτές κάνουν πάρα πολύ καλά και το ρόλο της ψυχολογικής υποστήριξης. γιατί δεν κρίνουν. Είναι αυτό που λέμε, εμπνέουν εμπιστοσύνη, ενθαρρύνουν την ανοιχτή επικοινωνία σε αυτά τα άτομα, σε αυτούς τους ανθρώπους. Επίσης, συμβουλευτική και η παραπομπή τους σε διάφορες υπηρεσίες είναι εξίσου σημαντική. Μην ξεχνάμε και την προάσπιση και ανάπτυξη πολιτικής υγείας, δημόσιας υγείας, όσον αφορά αυτό το κομμάτι, να γνωρίζουν όλοι οι πολιτικοί και όλοι γενικότερα στο σύστημα τι είναι το Kemp, γιατί είναι κάτι πολύ συγκεκριμένο, πολύ κλειστό, το οποίο πολλοί άνθρωποι δεν το γνωρίζουν και είναι σημαντικό να το φέρουμε στην επιφάνεια. Και επίσης, το confidential είναι πολύ σημαντικό. Η εκπαίδευση είναι και αυτό στο ρόλο του νοσηλευτή και πάρα πολύ σημαντικό. Και αυτό αφορά και τους επαγγελματίες υγείας στο νοσοκομείο. Και να μην ξεχνάμε και την κοινότητα και το peer support. Το είπαμε και χτες για το elimination της υπατήτηδας C. Οι ομότιμοι είναι πάρα πολύ σημαντικοί να διεκπεραιώσουν το έργο μας και να βοηθήσουν πολύ στην ανάκαμψη αυτών των ανθρώπων, με το να πάνε να τους βρίσκουν, να επικοινωνούν, να δημιουργούν εμπιστοσύνη και να μπορούμε και εμείς να τους βοηθήσουμε περισσότερο. Και έτσι βοηθείται και γενικότερα οι στρατηγικές μείωσης βλάβης. Επίσης, μέσα στα application που χρησιμοποιούν κατά κόρον, μπορούν να χρησιμοποιούμε μηνύματα τα οποία θα πετάγονται, ας πούμε, θα εμφανίζονται. Καταλάβατε πώς σε όλους μας συμβαίνει αυτό, που να αφορούν σε ασφαλές σεξουαλικές πρακτικές και να δίνουν άμεσα μηνύματα. Είναι πολύ σημαντικό. Και να έχουν μαζί τους kits, τα οποία να χρησιμοποιούν δικά τους καθαρά σύνεργα, για όσους κάνουν ενδοφλέβεια χρήση ουσιών. Και θα σας πω και το δικό μας μοντέλο στην Ελλάδα, την πρώτη πιλωτική μελέτη PrEP, γιατί εμείς ακόμα δεν έχουμε PrEP στην Ελλάδα, το παλεύουμε αρκετό διάστημα. Ήταν μια πιλωτική μελέτη με το όνομα Sophocles P4G, το οποίο έγινε στην Αθήνα, σχεδιάστηκε για να εντοπίσει μέσα στα δίκτυα των ομοφυλοφίλων τον πληθυσμό που διατρέχει το ψηλότερο κίνδυνο για μετάδοση του HIV και ο οποίος βάσει συγκεκριμένων κριτηρίων θα ήταν κατάλληλος για λήψη PrEP. Η αναζήτηση των high risk MSM έγινε μέσω αλυσιδωτής δειγματοληψίας RDS και με τη βοήθεια του Συλλόγου Θετική Φωνή. Το πρόγραμμα περιλάμβανε εξέταση για HIV, συνέντευξη με δομημένο ερωτηματολόγιο, το οποίο διαρκούσε 1,5 ώρα και το οποίο διενεργούσα εγώ προσωπικά, το οποίο είχε πάρα πολλές προσωπικές πληροφορίες και ήταν πολύ σημαντικό ο κάθε εξεταζόμενος να νιώσει ασφάλεια και να ανοιχτεί για να μπορώ να επικοινωνήσω σωστά μαζί του και να πάρω τις πληροφορίες που χρειαζόμουν. Δόθηκαν οικονομικά κίνητρα. Ο στόχος ήταν να συμμετέχουν στο πρόγραμμα 100 ενήλικες υψηλού κινδύνου. Η περίοδος που έτρεξε αυτό το πρόγραμμα, το πιλωτικό, ήταν από τον Νοέμβριο του 2016 μέχρι τον Απρίλιο του 2018. Συνολικά, το ερωτηματολόγιο το έκαναν 308 συμμετέχοντες, οι οποίοι 282 ήταν αρνητικοί για HIV, οι 21 διαγνώστηκαν HIV θετικοί μέσω αυτού του προγράμματος και από τις οποίες οι 5 ήταν νέες διαγνώσεις και δεν το γνώριζαν. Τα κριτήρια για να χορηγηθεί η PrEP τα είχαν οι 129 από τους 282 και στο πρόγραμμα συνέχισαν οι 107. Αυτό που κάναμε από τους 107 πριν ξεκινήσει η PrEP είναι να πάρουμε ένα καλό ατομικό ιστορικό, τη λήψη άλλων φαρμάκων, φυσική εξέταση λήψη ζωτικών, αποκλεισμό της παρουσίας συμπτωμάτων πρωτογενούς λίμωξης, να δούμε ότι έχουν αρνητική εξέταση για HIV κατά προτίμηση ELISA τέταρτης γενιάς, και σε περίπτωση πρόσφατης επικίνδυνης έκθεσης, καθυστερούσαμε να ξεκινήσουμε PrEP για 1 μήνα και επανεξετάζαμε. Συμπεριφορές υψηλού κινδύνου θεωρούσαμε τον αριθμό των συντρόφων, το ομαδικό σεξ, συντρόφους με HIV θετική λίμωξη, σεξουαλικώς μεταδόμενα νοσήματα, chemsex και επικίνδυνες σεξουαλικές πρακτικές όπως fisting, χρήση προφυλακτικού, χώροι cruising όπως σάουνες και άλλοι χώροι διασκέδασης. Γιατί τους χρησιμοποιούν πάρα πολύ σάουνες όσοι κάνουν chemsex. προσυμπτωματικός έλεγχος για σεξουαλικώς μεταδόμενα νοσήματα γινόταν για γονόρια, σύφυλλη και χλαμίδια. Επίσης, ελέγχαμε για απατήτα Β, Α και Σ. Και εννοείται, ανάλογα την εμβολιαστική τους κάλυψη, παρεμβαίναμε και εμβολιάζαμε για υπατήτα Β και υπατήτα Α, όπως εδείκνυται. Και κοιτάζαμε και την κάθαση της κρεατινίνης, γιατί η PrEP επηρεάζει την νεφρική λειτουργία, το TDF συγκεκριμένα, που δώσαμε εμείς. Το follow-up ήταν σε ένα χρόνο 6 επισκέψεις στο νοσοκομείο, όπου επίσκεψη 0 ήταν το screening, μετά ξεκινούσαμε PrEP. Στο visit 2 ήταν 1 μήνας μετά την έναρξη της PrEP, στους 3, 6, 9 και 12. Όπου εκεί πέρα γινόταν έλεγχος για HIV, σεξουαλικώς μεταδεδομένα νοσήματα Β, Σ και Α, εμβολιασμοί, αν υπήρχαν παρενέργειες, ελέγχαμε την νεφρική λειτουργία και τη συμμόρφωση με την PrEP. Και να πούμε λίγο τα αποτελέσματα που βγήκαν από αυτή τη μελέτη. Συνολικά ήταν 100 συμμετέχοντες, με μέση ηλικία 34 χρονών. Τη 12μηνη λήψη PrEP την ολοκλήρωσαν 74 συμμετέχοντες. Είχαν πάρα πολύ καλή συμμόρφωση. Ξεκίνησαν με σεξουαλικούς συντρόφους να είναι στους 25 και κατέληξαν στους 18. Κάνανε από την αρχή Kemp στο 28 και σταθερά συνεχίσανε, δεν αλλάξανε τακτική. Ούτε όμως άλλαξε και η επίπτωση των σεξουαλικών μεταδεδομένων νοσημάτων. Αυξήθηκαν βέβαια τα ποσοστά του εμβολιασμού, γιατί εμβολιάζαμε συνέχεια. Και αυτό το συμπέρασμα που καταλήξαμε είναι ότι η PrEP χορηγείται προφυλάσση, δεν αυξάνει τον κίνδυνο συμπεριφορών, υπάρχουν ήδη και συνεχίζονται. Ίσα-ίσα πιο πολύ φαίνεται σε αυτούς τους ανθρώπους στην υγεία, στο σύστημα υγείας και τους εξετάζει συνέχεια. Και βλέπουμε ότι είχαν συμμορφωθεί και στην PrEP τη λαμβάνανε όπως έπρεπε. Παρ' όλα αυτά είχαν δίπλα τους έναν νοσηλευτή που συνέχεια επικοινωνούσε μαζί τους για να τους διατηρήσει στο σύστημα της φροντίδας. Και εδώ είναι το πρόγραμμα από ποιον χρηματοδοτήθηκε και τις ευχαριστίες στο πρόγραμμα και σε όλους τους συμμετέχοντες. Και θέλω να πω και ένα μεγάλο ευχαριστώ στο Insurance Committee για όλη τη συνεργασία, για όλη τη βοήθεια, την επικοινωνία μας και την προοδευτική τους σκέψη. Να πούμε εδώ κάποια πράγματα για το Kemp, γιατί δεν είναι τόσο αποδεκτό να παρουσιάζεται γενικότερα. Και θα ήθελα και εσείς όλοι παρακολουθείτε, να αναμειχθείτε και να πείτε και εσείς τις δικές σας εμπειρίες και την καθημερινότητά σας ως νοσηλευτές. Το επάγγελμά μας είναι πολυδιάστατο, είναι σημαντικό και οι ασθενείς, πώς το λένε, είναι πάνω σε εμάς, δηλαδή βασίζονται σε εμάς. Και αυτό είναι το πιο σημαντικό. Σας ευχαριστώ πάρα πολύ.
Thank you so much, Martha. It's quite a challenge for us all, and I think it's really good to actually experience what it can be like with English as a second language and Greek as a no language for us, for me. So well done, and we got there with the app, so it was really lovely. If you'd like to take a seat.
Ελπίζω να μην δυσκολευτήκατε στην κατανόηση. Δεν ξέρω. Understand the application?
We got there in the end.
Okay.
Yes. We are very grateful that your slides were in English because we could follow along. So a big thank you to Martha. And I have to be honest, it sounds like a really big project and lots of work in that. So thank you so much. What we might do before we go into the we won't maybe do questions directly now, but we're going to open the panel, and I'd just like to introduce our panel. And each panel member, if you're happy to just share a little bit about your program, and then we'll, excuse me, I've got to go through the app here. We'll open the floor for some questions particularly, and you know, bear with us. It's good to actually see how these applications work, so I'm really grateful for everybody's patience this morning. So firstly, I would like to introduce Maggie Biser. Yeah, great. Okay, so Maggie's from Boston Healthcare for the Homeless program and is an adult nurse practitioner with this program where she provides primary and specialised HIV, HCV addiction and gender care for people experiencing homelessness and or using drugs. She founded the BHCHP-HCV treatment program and leads its educational research and advocacy efforts.
Dive in? Okay. Hi, everybody. I'm very happy to be here. So, as Alex said, I'm a nurse practitioner, but Boston Healthcare for the Homeless program is a pretty amazing and unique program that is really founded in nursing principles from the very beginning. So, as an organization, we are a primary care community health center, but we operate at over 30 sites, and many of those sites are shelter-based clinics that were originally nurse clinics entirely, and still really are nurse-run with an overlay of clinical primary care and work. And over the years, we have flexibly tried to respond to a number of crises in our patient population. First TB and multi-drug resistant HIV in the 90s, and then more recently the overdose crisis. 1 in 4 of the patients that have died in our practice in the last 20 years have been from drug overdose, and we have fentanyl in Boston pretty much exclusively. But we have risen to also respond to COVID and to integrate PrEP and to integrate very low threshold prescribing of office-based buprenorphine and a number of other cool things. And I just want to highlight sort of where nursing has emerged as the key component in those programs. So I started the Hep C program 10 years ago, and I love it and I could talk about it forever, but I'm going to skip over that just to talk also about some other things. So we have a buprenorphine treatment model that is almost essentially nurse-led. So our nurses see patients usually weekly or more frequently or less frequently in person or via telehealth. They independently work on dose adjusting medication to meet patients' needs. They do the full range of harm reduction counseling and support. We also have a pretty unique program called SPOT, which is the Supportive Place for Observation and Treatment. It was the first of its kind in the country, in the States. And it is a place we don't unfortunately have drug consumption rooms where we are, but it is a place where people who have used substances can come and just be in a safe space. So they may have oxygen delivery. They may, in some cases, we can do IV fluids. They have vital sign monitoring. They're jerry chairs. People can just sleep if they need to sleep. And if they are amenable, if they're awake and want to also address health needs, we can do that. If they're interested in treatment, we can do that. If they're interested in medications for opioid use disorder, we can, but we don't have to. We don't take names unless people want to volunteer that. It's an incredibly low threshold space, and that is run by the nurses in our program. And they have also developed a sedation monitoring protocol that is really pretty revolutionary. So we talk about naloxone a lot here, but we have found that, unfortunately, naloxone can cause some harm for our folks as well. And so we have the 4 milligram intranasal spray. We've shifted much more to using the 1 to 2 milligrams, like a whisper of naloxone in some cases. And in many cases, we're working to try to only use oxygen when we can. And so that has been very nurse driven. Another area has been in HIV prevention work. And so we had an HIV cluster of infections among people who are homeless and injecting drugs in a half-mile radius of where we operate. And over about 3 years, we had 145 new cases of HIV. And so the response for that was really massive and rapid. Unfortunately, not rapid enough. But to prevent more infections. But one of the ways we have done that has been to empower our HIV prevention and screening team, who are mostly non-clinical staff and are doing serum-based testing, and it's syndemic testing. So all of that testing is HIV, hepatitis C, syphilis, and then if people are able to do urine, chlamydia and gonorrhea. We also do HIV RNA testing every time in the context of this very high incidence rate. And PrEP prescribing either via telehealth, like the case manager would say, I did labs, can I call you? And I would be on the phone with the patient and the case manager and facilitate evaluation and prescribing in that moment, and then putting medication in that person's hand for right then, with nurses in our outreach setting holding medication, delivering it on a directly observed therapy basis or a weekly basis with pill boxes, and sort of really flexibly trying to respond to whatever people needed. But also we developed a nursing standing order, so nurses could do that evaluation, making sure people don't have signs of acute HIV infection, they don't have hepatitis B, and then being able to start 7 days of TDF in our case. While waiting for test results, to really we cannot lose people in that moment. And so nurses have just been fundamental to that situation. I think those are the big things I wanted to pull out. Also, wound care, we have quite a bit of xylazine contamination in our fentanyl. And my colleague Taya Johnson is a nurse practitioner. She did a great podcast on the curbsiders, if you're familiar with. It's a US doctor-based mostly educational podcast, but she has developed amazing wound care resources for xylazine wounds, and that's available for free on a podcast called The Curbsiders. And then in general, our program is deeply, deeply nurse-oriented. I'm one of 45 NPs in our program. We have over 250 nurses who work across our program. We have, like I said, 30 sites. We see about 10 to 11,000 patients a year. And then we also have a medical respite program, which is 100 beds for people who are too sick to be really in the street or on the shelter with an acute level illness, but not really hospital level of care. And so we do, that is it's 24/7 nurse provided, and people meet with a medical provider every day, and that's often a nurse practitioner to address the entire scope of care, from harm reduction, addiction treatment, but also colonoscopy prep and hypertension management and diabetes stabilization and HIV stabilization, and sort of bringing the full scope of primary health care to the most sort of low threshold sites to try to really improve the health, the kind of holistic health of all the people we take care of. And I'll stop there.
Holy moly. Such amazing programs, and hearing some of the intersection of both yours and Martha's, the importance of PrEP in that population where you had the HIV cluster, so important to be able to get out there quickly and be reactive. And what a huge network. And all those nurse practitioners. I don't know who's jealous, but I certainly am in Australia, where they're very limited in comparison. So amazing. Thank you so much. Now I'd like to hand over to Brett. Sorry, here we go. Brett is from
New Brunswick, Canada.
Thank you. My phone's seized up. Yeah, awesome, please.
Yes, my name is Brett McDonald. I'm from New Brunswick, Canada. I have a shared capacity with partial work in the ER in Fredericton Square. Kind of got my grounding post nursing school, and I work at Riverstone Recovery Center as well. We have 3 posters, 86, 87, and 88, if you'd like to stop by and see them. I joined the panel because this is more, the chemsex in relation to the LGBTQ community is very much an emerging dynamic patient population, and I feel like it needs some priority work. Myself, in full disclosure, I did legal pornography to get through nursing school, so part of working sex trade and understanding the safeties and parameters in harm reduction for myself. I'm also in a committed relationship with my partner, we are in an open relationship. Both of us are on Doxy PrEP, so it does work, it is efficient. I would be more than happy to answer any questions for nursing considerations, how those aspects work. Education is very expensive, so lots of people find different means. Most chemsex integration or talks, at home we call it P&P, or party and play. It's usually in a dark form, or folks usually view it as like a very dark intersection of how people work or maneuver the system to gain funds. OnlyFans is another way. All are legal. My bosses know. And so does my governing body that holds my license, because I only processed in the legal system. But also along the way, I do have friends who have kind of lost their way with chemsex. Some have lost their lives. So it's very important that this area of harm reduction is talked about openly in spaces like this. The dynamic examination of how this works, what's the drivers, how to keep people safe in ongoing sessions like that. So yeah, as for nursing considerations, I wrote down quite a few, and it kind of mirrored our gal's presentation here today. But mostly it's just understanding, you know, in certain care areas such as the ER, such as the medical floors in our area, you know, the vast workload that nurses are experiencing now may lack, you know, partial empathy for some of these folks who may miss things. Wonderful things that we do at Riverstone Recovery Center for harm reduction is we also have open capacity for a lot of sex trade workers as well. So keeping those folks safe, and it's really great to say to somebody who is processing sex trade that, hey, I do doxy prep, it's fine, I'm here. And we don't necessarily share our experiences with our patients as much unless it can be documented, because, you know, when you self-disclose, sometimes they can turn it around and use it against you. So in your self-disclosure of how you provide care for your interventions for folks in this area, as long as it can be measured, documented, say, hey, I'm on it, it works for me, I'm here now, these are my results, I haven't, and honestly, over the past year, I have not had any other infections, co-infections, and I believe that's primarily due to the new Doxy Prep program that is facilitated in Fredericton. Now, my family doctor is not able to take my partner on as primary care just due to the capacity that she carries, but due to our openness in our sexual activity, has agreed to provide scripts for him for PrEP. And I know that there's a lot of issues throughout our country, especially with the lack of education in New Brunswick around this type of care, and especially those living with or affected by HIV. So I would empower all of you nursing staff or nursing folks to really engage in your LGBTQ communities who may be taking part in these activities, that there are answers, and to keep pushing for if you cannot find somebody to provide PrEP. Also, and with the doxy as well. Also, I've heard some emerging issues with other nursing care trying to provide PEP with their folks who may be injecting drugs as well. That should be a no-brainer because obviously the cost to the healthcare system for ongoing ART therapy is very expensive. So if you can upstream that and provide that care would be very beneficial. So yeah, I would be very open to answer any questions that folks may have in regarding those two areas, and that's why I joined this panel.
Yeah, amazing. It's amazing, Brett. Thank you so much. And one of the things that I was thinking during the first session and also the second is that the use of the value of peers in all of our areas, but particularly in this area as well, because it's a very sensitive, private area that people may not actually want to disclose, and so great respect for that. Okay, so now our third panel member, Fasale.
Pumzile.
Pumzile.
Yes, you're very close, I think.
Please, welcome.
Hi, everyone. My name is Pumzile Mgomezulu. I am from South Africa. I work for an organization known as TB HIV Care, which is in 3 provinces where PWID, which is People Who Inject Drugs program, is concerned. Namely, it's in Tshwane, another one is in Durban, and also in Mpumalanga. So, you know, our PWID program consists of health professionals. We have qualified nurses that prescribe and manage ART and PrEP. We have social workers. We have peers, which play the most vital role. I think that is something that is very common because of most of our peers are also from the community. So it becomes very easier for them to actually relate and be the forefront when we need to provide our services. So our services are offered in our drop-in centers, but there's only 10% in the drop-in centers. And 90% is actually on outreach. And some of the biggest challenges in South Africa, and mainly you know, with people who inject drugs as a key population, is the homelessness. So we have over 70% of people who inject drugs that are homeless, which makes it a bit difficult to actually try and, you know, when I was listening to other presentations, there were so many innovations. There's telehealth, there's this and that, and I was here thinking, this is a dream for some of our programs in South Africa because of we are still relying on ensuring that we adhere to a schedule because our clients do not have cell phones. If we miss a client at that particular time that we were scheduled, it means that client is going to go a full day without their treatment. They're going to go a full day without their methadone. So chances of us finding that client, they are slightly slim. So we really, really try in our model of care to ensure that among everything that we do, that we provide, we always stick to the schedule. And the clients know exactly where we are at what time, unless if there's an earthquake, which is unlikely. But we really, really try to make sure that the services are delivered to them and on time. We also have a very high positivity rate. So there was a recent biobehavioral survey study that was conducted at TB HIV Care, led by our consultant, Dr. Andrew Scheiber. In one of the 3 provinces, we had a 72% HIV positivity rate. And we had 71% of hepatitis C. So it's amazing to see what other countries are doing. And then again, when I look at it and understanding that we are from a third world country, some of the things we look from a distance and say, it would make such a great difference if we had those opportunities, if we had those models of care also in our country. And to try and make sure that there is, continuous service, we actually combine our comprehensive service package where there's HIV counseling and testing. So our peer educators are well trained and certified as HIV testers and counselors, and we provide also index testing because we have found that there is more transmission of HIV through the sharing of injecting equipment. So we do that through index testing. And there's also social network strategies, which is very good in terms of helping us find more clients. So a client will come and, would say, I've heard about the services from a friend of mine when we're incarcerated. So this is how it now opens up to more PWIDs actually accessing the service. And we have adherence clubs as well, with a form of support groups where we look at clients that are initiated on art, and we try as much as possible to have motivational activities to actually keep them on art. Our PrEP uptake is also a bit low because we are still using oral PrEP with the hope that we'll also be able to transition to the injectable PrEP. So HIV prevention is also strengthened through the needle and syringe program, which we're really, really trying to strengthen and make sure that there is consistent supply and a lot of health education. Because we can provide all of these services, but if a client does not understand the need, to prevent HIV, to protect themselves, then it is just all in vain. So part of the complementary services that we provide, because of most of the basic needs of our homeless PWIDs are not met, we really try to actually give them something that is going to motivate them to also consider their health as a priority. So this includes our shower facilities. We have shower facilities. We have areas where they can wash their clothes while they're taking a shower. And we also have like a cool space where they would just sit, do some artwork. And it has now changed into an income generation activity where we're working together with COSAP. With Sanput. So what we've actually found is that the more clients that we enroll on, OAT, once they are now in the space of deciding what they want to do with their lives, if there's nothing that is keeping them busy, it becomes easier for them to literally just go back to that corner. So we keep them occupied, and at the same time, they make income out of all the hard work that they would have done. And we also provide dignitary packs where it's tailor-made for women, also tailor-made for men. So these are some of the little things that would be taken for granted, but it actually plays a very vital role in each of our clients. And then we also have daily nutritional packs that we're providing because most of them don't even know when the next meal is going to come from. They hustle. In South Africa, we call it Zula. So we really try to kind of give them something. And on Fridays, we have a hot meal Fridays where the team would cook up a storm, like a full plate of food with several colors. And it's something that they also really appreciate. And during those times, that is when we get the opportunity to also engage with them. That is where we also find our lost to follow-up clients and like, no, come back. What happened? And then, so it gives us that ability to bring them back to care, and at the same time, just keep on building those relationships and giving them a home, if I may call it, or a safe space. Yes, and some of the challenges that we are experiencing, there is still some confiscation and arrest from the police officers. You know, sometimes you'd find reports that they've actually confiscated needles that were still sealed in a pack, you know, and there are certain boundaries or challenges that at this point we really trying at our level, at our capacity to try and breach, and that would be through continuous sensitization, you know, just going to those police stations, just trying to engage with them, make them understand our services, and also invite them to all of our service points, and whenever we're doing an outreach or any kind of promotional program. But we win with some it's still, yeah, it's still a battle, but yeah, we're sticking to it. And we also have some reports around the ill treatment in the public health facilities, you know, just because a client comes in looking for service and they don't look hygienically well, or they will be kept waiting for like 3-4 hours, and at the same time, if the client is now withdrawing, you know, the need to seek service will no longer be there, and they will leave without getting any services. So we really try to strengthen advocacy while also trying to do at what we can at you know, at our capacity. And some of the strategies include also community advisory groups where we try to engage with clients just to find out exactly what is it that we need to do for you, because of sometimes it's easier for us to think the clients need this, the clients need that, but when we engage with them, we actually are able to find out exactly how we can restructure our programs to better suit their needs and actually deliver the service that they really need instead of what we think they need. We've also developed strategies like a buddy system, because we've seen that mostly clients that are having a next of kin or support person are more likely to be retained on treatment. However, those that are homeless, it's unlikely for them to have like a mother or a brother who would come in. So we have a buddy system where it would be 2 clients. If they're sleeping in the same area, maybe under a bridge, and the other one is unable to make it to the facility, the other one would be able to take their treatment for them. And we'd also formulate those support groups where they continuously engage and they understand, and they would remind each other to say, no, I can't pick up treatment for you this month because you remember you need to take your viral load. You know, so it becomes very much of a community that is surrounded by support, and in turn, they become the support structure for each other. Yeah, so I think that is basically that. There's a lot that we can really talk about where our program is concerned, but mostly it is, if we were to compare with any other countries, I think we are still at the level where we are looking at what is best for the person at this point, and it really plays a vital role. Thank you.
So many wraparound services there. Like, it's inspiring, and you know, there's this theme through everybody's talks around homelessness. I think that's something that we are constantly addressing, is the socioeconomic challenges of our clients. And so it's amazing to look at all those packs and the provision, and I love the buddy system. You know, I love that, because I often see the guys that I'm working with who are living rough or at risk of homelessness, that they do actually look out for one another. There is a community there, so it's great to actually involve them in their own care and also their comrades. So thank you so much. So we have actually got 20 minutes of this session. It's quite a long session, which is great because it means we've got an opportunity to open the floor to questions. I also do have some plants in the audience who have their own models of care, which we really love to hear about. If there's other questions and you want to answer those, please do. Would you like to just firstly stand up and identify yourselves? Just to say hi. Plants. But not. We had lots of EOIs, as I said, and I just wanted to, you know, bring everybody to the forefront. So, Lucy?
Frontline nurse practitioner with Doctors of the World in Montreal. I work at a nurse-led proximity clinic in the Native Friendship Center downtown Montreal. So our clients, our patients are mostly people, everybody who spoke has the same type of patients. And us, it's mostly indigenous, and it's indigenous-led. I'm indigenous also. So it helps a lot for indigenous patients that are homeless, vulnerable, HIV, hepatitis C, have problems with addiction, to be in a safe space that is indigenous with an indigenous nurse. And we have traditional healers that we work with also.
Amazing.
But we have our challenges. Means to contact our patients are difficult. Phones are lost, sold, or non-existent. And there's many, police is also a big issue. We have a lot of problems with sex trafficking, especially our Inuit women that come from the north and are brought to the south being Canada, Montreal, for sex trade. A lot of violence, gender-oriented violence towards our LGBTQ and women on the streets. So it's a challenge, and I think everybody gets it what it is.
Yeah. Fantastic. Thank you.
Hello, my name's Pam Ford. I'm a nurse in Regina, Canada. I work with a team of outreach workers and lab techs, and I have peer support who has lived experience, but he's now a social worker, although he doesn't tell anybody that he is.
That's amazing.
They just know him as Rob on the street.
Yeah.
And we don't have a clinic. We are completely mobile, so we are in all of our community centers that we would go to, so needle exchange, soup kitchens, drop-in centers. We have one safe injection site, and we go in, we offer testing for Hep C, HIV, syphilis. If they have a bathroom, we'll do the rest of it. We do offer incentives to get people to encourage them to be tested, and then we connect them to care. In my province, our government has ridiculously decided in February to not allow us to give out supplies for inhalation any longer, so we no longer have that option. So when I do get funding, I actually use that funding to buy pipes. Our program in our province has always been a one-for-one needle, but it used to be that if you had no needles and you walked in and you asked for needles, you get a 10-pack, so you get 10 needles. It's now back to one-for-one, so if you don't have any, you don't get any. We've seen a significant change in people that were smoking, switching back to needles, because at least you could get a needle. So of course, lots of people are using, a lot of shared equipment again, because access is not as easy as it was. The talk that was earlier today, they were talking about the different things that they use for smoking with. Ours, a lot of them use light bulbs now. I was like, what the hell? Why are we finding all these light bulbs all of a sudden? But yeah, light bulbs is a big one. So yeah, just, that's not really what I do, but we see it as a need to offer. So it's also an incentive. They'll come in and get testing because they know they can get free supplies from us. So doing all that, and majority of my people are also Indigenous. I live in a province where it's a high population of that. Most of my people that I see also live rough. So I live in a province where in the winter, -30 is very common. So living rough is really, really rough.
Really rough.
So, we also, from October to about May, we have some warming centers that are open from 9 p.m. till 7 a.m. So we also have staff that go in and help to offer testing and things like that. So
Amazing. And how challenging when you had something and it was taken away.
It's
You just think we're going to keep moving forward.
Yeah.
But then when something like that happens, that could just be so difficult to
Yeah. We were thinking we were finally sort of getting on top of, from COVID with all the restrictions that we had. And although we did have needle exchange and things were open during COVID, it was limited hours and limited, access to it because only one person could be in the building, and made it very difficult. So of course our numbers, all skyrocketed, and, we were just starting to see some, maybe significant change where it was going back again, and we're right back to that all over again. So
Thank you.
Anne, a nurse from Kool-Aid, and I think I've spoken earlier about the programs that we do regarding people experience homelessness, but we also have a sexual health program that I thought I would just highlight here. In Victoria, when PrEP first started, we had no family physicians who were willing to take it on that we could find. And so because our physician group is really passionate about helping underserviced people, they agreed that nurses could start a PrEP program and they would oversee writing the prescriptions. But the nurses did sort of all the legwork. So we have a drop-in every Thursday night for 3 hours. It's a men's testing night, we call it. We've partnered with AIDS Vancouver Island, and they have an outreach worker who sits in our waiting area and provides information for people who would like it. And then the nurses we go out, we have 2 nurses working that evening, and I would say in the average night we see about 15 men per night for initiation of PrEP or STI testing, doxy-PEP as well. And fortunately, we just do all the blood work and all the testing on site. And we also are able to treat people for STIs on the spot as well. So if someone comes in symptomatic, we can treat with the medications. We do a lot of syphilis testing. Interestingly enough, we are not seeing a ton of syphilis in our men who have sex with men population anymore. It's jumped over, and we see it in our primary care practice, just in the general population that we serve. So that's an interesting phenomenon, and I think probably speaks to the engagement of this population in health, the frequent testing, getting treated right away if they're positive, so you're just not seeing the same transmission level there. We also go out to Beacon Hill Park in Victoria, which is a common cruising area for men, probably more commonly men who are on the down low, if you will. And so we take out our mobile van, and we have a peer worker and a nurse on the van, and people come in and get tested anonymously. They can pick up supplies, and so we do a lot of point-of-care testing. We take our immunizations, so we do Hep A, Hep B, HPV immunizations on our outreach, also on our men's testing night. We also have a women's testing night, so we go out on our van just twice a month with our local agency called Peers, which is a old-fashioned name, Prostitute Empowerment Education Resource Society, but basically it's a service for sex trade, women who work in the sex trade. And so we partner with their van, so our 2 vans park together in the evening, and again, we have a physician and a nurse on the van, and we have the capability of doing full pelvic exams. We will provide medical abortion, we provide birth control, and then we also, at that time, will start people on OAT, whatever needs to be done, we do. And that's twice a month, and then we have a women's clinic in the health center that does, we'll put in IUDs, do endometrial biopsies, again, the medical abortion, whatever needs to be done. And that is, we have a female physician and a nurse on site for those nights. And again, offer PrEP for women who work in the sex trade. As people probably are aware, there's not enough evidence right now to support doxy-PEP, the doxycycline for the chlamydia gonorrhea. We've just recently written a letter to the BC Centre for Disease Control, which is the agency that controls it at the dispensing of the publicly funded doxy, to try and get them to do some studies, because there's one study out there that shows there might be some benefit for women who work in the sex trade. And so we're really advocating to get more research. So if anyone is looking for a research project, I would encourage someone to maybe consider doing that. Thank you.
Awesome. Thank you, Anne. So many incredible programs. So if I'd like to open it up to the floor for any questions to our panelists, to our speakers. Please, a couple of microphones, please do. Yeah.
Hi, Brendan Harney. I'm originally from the Burnout Institute in Australia, currently in Montreal at the University of Montreal as a postdoc. I like to say in these sessions, I'm not a nurse, but I've worked with nurses. I love everything you do, so thank you so much. So my question was for the guys from London. So you presented some incredibly high rates of STIs. First question, was that active syphilis?
Yes, most of it was.
Okay, wow, yep. And in terms of chlamydia, gonorrhea, Julian, we spoke yesterday briefly. Is that just vaginal swabs? Like,
So we do oral, vaginal,
Okay.
rectal swabs or a urine sample.
okay, cool.
So it's
Yep.
whatever they say, whatever type of sex they say they're having, then we'll offer.
Okay, great, because I think that's like a major ongoing issue. People aren't doing the other sites, and in Australia, we are pretty lucky. Like sex work is, we are quite progressive. It is, quite, it's essentially fully legal, but we are seeing slow upticks in STIs among sex workers, and we think it's because of oral sex. With no one uses condoms for oral sex, right? Yeah. So yeah, great to hear. Thank you so much.
Thank you. Yeah, Leah?
Thank you, everyone. Just mind blown, so many questions. I think everyone's just doing such important work. I have some theme-based questions, and really anyone could take them around HIV prevention. Number one, what is your experience around HIV prevention and women? And how are you doing more? Because I would guess no one has great uptake, but if not, how are you doing more? Second question is around post-exposure in pocket. So with PEP, you could actually prescribe it in advance, so people don't have to sort of rush to a provider in that 72 hours. And then, sorry, I actually have a list. And then this actually one is for Martha. Martha, in your work where you delay initiation by a month after a high-risk exposure, would you ever consider just prescribing a month for prevention and then doing a test and then moving on to prescribe 3 months, if I understood the slide correctly?
Before initiation of PrEP, we did screening for HIV. If the participant told us that had a high risk exposure, we delay the start to distribute PrEP.
One model.
1 month, and again we screening.
So one model people are trying is even with high-risk exposure, especially considering your new
Our
diagnosis
program was only for high-risk MSM.
Yeah, and so since you had so many new diagnoses, and I think also in Boston,
Yes, I had new diagnosis.
But would you ever consider just, even if they had a high-risk exposure, just prescribing a month, knowing, you don't know their status, but then doing the test again? Because in that month, they might have another high-risk exposure, and you're just delaying.
Yes, but they have take for 1 week PrEP every day. So they are, there's no danger. Like the studies. We need daily PrEP for 1 week. Have the rate of the drug in the organism.
Let's chat after. Okay.
I can say we definitely do PEP to PrEP often. So if people I would love to speak to your earlier questions, Mia. Also, so I think engaging people who inject drugs in HIV prevention services, I think, has been historically difficult, and being able to offer low threshold screening where people are using is, I think, the number one thing, but also the retention and the engagement is really about relationships and sort of being consistently in those spaces and being able to, especially for people who are homeless, being able to get over the logistical issues around medication storage and pharmacy negotiation and things like that. And so so testing in SSPs or on the street, and I think I mentioned we do serum testing, we aren't doing point of care. Being able to be there consistently and incentivize that with, we have McDonald's or Dunkin' Donuts gift cards is a very, very common thing. And then being able to write the script and actually having our staff get it at our pharmacy, which is in our building, which is next door to the SSP, but still potentially a little too far away for people in the moment. And we do short scripts, which we recently were audited by an outside pharmacy, and they were like, you're not supposed to have Truvada out of the bottle for more than blah, blah, and we're like, fuck you. So we often do 7-day scripts or shorter, 7 days with refills, or we fill a month and we put it in our like harm reduction nursing med cart, and people get like a day or two at a time. So we engage many more women in those spaces, just kind of across the board. And then we also unfortunately, the police pay people to pick up needles, but they don't provide them with the safety gloves to do that in a appropriate way. And so people get needle sticks all the time. And it's perverse. And so people come in often because they perceive risk, their own injection risk, or this community environmental risk. And so very, very often we're putting people on post-exposure prophylaxis. And I think one thing to say is we draw bloods, but we start meds that day, whether it's PEP or PrEP. And if it's PrEP, we do limit it to 7 days until we have results, but with a very close plan for, we will come find you here, or you come find us here, and we'll continue that prescription.
Great.
We also are doing a little bit of injectable PrEP, but I do not think it has had nearly as much uptake as we would have imagined early on, and now that there's lenacapavir data, and it's like, forget about it. Like, we need lenacapavir now.
Yes. Awesome, thank you.
Hi, sorry, back here. Yeah, wonderful to hear about folks' experiences. And what I wanted to ask about was nurse-led protocols particularly for PrEP initiation, but just in the space sort of more broadly, thinking about task shifting or task sharing, given the lack of the number of people who need access to a lot of these services, particularly HIV preventive care, and the limited number of prescribers, particularly physicians, but also advanced practice providers, particularly depending on sort of what country or what practice environment you're in.
Who wants to take that one on?
I can. I'm sorry. I don't mean to monopolize. We wrote a protocol and just got it through our clinical standards committee within our own organization. And it basically says if a nurse is evaluating somebody for HIV, for PrEP, if they don't, I think it's very, very clearly, like, if there's evidence that they do not have active Hep B and that they do not have signs and symptoms of acute HIV, you can like put the prescription in the name of our HIV program director for 7 days and then follow up from there. So it is pretty limited, but it's meant to we have to respond right now. And so how do we get medication in people's hands? And that was one of the ways. We've since lost the funding for our PrEP nurse, but the nurses that work in those outreach settings have sort of taken it on. But it basically is the same as like nurse standing orders for vaccination and like empiric STI treatment as well.
Tatiana Deshka, Alliance for Public Health Ukraine. It's just about a month since we initiated KBLA as prevention in MSM group. And we've been, actually one of the reactions was people speaking about how painful the injection is, and wanted to ask for any kind of advice you would give. Is it really maybe enhanced counseling before kind of getting the person in, or any other kind of recommendation anyone in the room would have? Because I think this is one of the largest kind of reactions that we have had. Although the program is going kind of overall well and a lot of interest in it, but kind of just this. Yeah, thank you.
I'm not sure if anyone else has got something. I know that our sexual health team have started to keep lots of ice packs, and they actually have people lay down for a while afterwards, and they put an ice pack on just to kind of cool the area. But other than that, it's quite a thick, big injection. So,
we absolutely have had some people who don't tolerate the injection well. We've had a couple of people on rilpivirine discontinue and have had like exacerbations of sciatica, and like whether or not that was actually related, just they equated it with that. We have some people that get they get administered dorsogluteal instead of ventrogluteal, and that has been helpful for some people. You can do that. But it's not great, frankly. I mean, honestly, I think it's, I think of it as like telaprevir or boceprevir with hepatitis C treatment. It's like the beginning of a shift in practice, but it's intensive and it requires a lot of very tight monitoring, and it's painful, and those injections kind of suck. Like, the next generation of this is going to be so much better for everybody.
All right, on that note, which has brought us right to time, I'd like to thank all of our speakers and our panel members and our audience plants and everyone who participated and came today. Please keep up the amazing work as nurses. We are so important as we head towards elimination for viral hepatitis, but also in all the other wraparound services that keep the person at the centre of the care we're providing. So thank you for coming today.